Good morning. Today I will speak on how sex hormones can affect the human fascia. The fascia, as the connective tissue, is made of different kinds of cells, resident and transient cells, embedded in a lot of extracellular matrix. We can divide the extracellular matrix in two components: the fiber components made of collagen and elastic fibers that are involved in the force transmission at distance, and the water component, very rich in water, proteoglycans, and glycosaminoglycans, especially the hyaluronan, that is the key molecules that can permit the gliding properties of the fascial tissue. It permits the gliding of the different layers of the fascia and of the fascia with respect to the muscle. We have demonstrated that the amount of the hyaluronan is constant according the site and the type of the fascial tissue. So it is the enough quantity that can permit the correct gliding in a physiological fascia. But in this dysfunctional situation, the hyaluronan becomes much more sticky. There are binding proteins and the viscosity is increased. It means that in that case, the fascial layers are not free to move independently, and so the fascia is more rigid and more stiffer. Also, the fiber components can change. The fiber component of fascia are made especially of collagen type 1, collagen type 3, and fibrillin and elastin. And these components can change the relative amount, changing the properties of the fascia. So if there is much more collagen type 1, that is the most rigid, the fascia has more rigidity and more stiffness. If, at the contrary, there is much more elastic fibers and collagen type 3, the fascia can be more elastic and more soft. But there are a lot of factors that can influence these changes in the extracellular matrix, both physiological and pathological factors. First of all, the anatomic site and the type of the fascial tissue. So each type of fascia has different properties, but also some chemical factors can change the extracellular matrix. So we know, for example, that the pH and the temperature can alter the viscosity of the hyaluronan-rich matrix. As Professor Stecco has already showed, also the aging can change the extracellular matrix characteristics of the fascia, but also a lot of other also external stimulation can alter the fascia properties: mechanical stimulation, drugs, chemical stimulation, and hormones. That is the topic of this speech, of this presentation. The idea from which we started is that from a clinical point of view and also from the literature, we know that there are sex differences in pain. So the prevalence rate of musculoskeletal pain is higher in women with respect to males, with a greater onset of chronic conditions. And also, with the aging, in parallel happens also a decrease in the estrogen levels, and it was already demonstrated that these two conditions, aging and decrease in hormones, can cause an upregulation of the factor IGF-1, which enhances the collagen synthesis. So the connective tissue in general can become more rigid. In our opinion, it is very important to understand how the sex hormones disorders can dysregulate the fascial tissue to permit to understand better the gender differences in myofascial pain. So the aim is to help clinicians to make a more targeted diagnosis and a more targeted treatment. We focused our attention only on estrogens, but in the next future we are planning also to study progesterone and androgen hormones. in general, when there is an estrogen deficiency, like what happens during the menopause, this estrogen deficiency is associated with an increase in fibrosis and consequently in increase in pain. When we have an increase in estrogen levels, like during ovulation or, for example, during pregnancy, there is much more laxity of the ligament of the ankle. But in general, when there happens high fluctuations in these estrogen levels, the female can have much more pain, musculoskeletal pain, joint pain, depressed mood, stiffness, and in the clinical practice, it's already demonstrated that the females that have an oral administration of estrogens can affirm a clear analgesic action. Okay, so first of all, we have demonstrated that the human deep fascia express in their membranes the receptors for sex hormones. We have demonstrated in different kind of deep fascia the expression of the estrogen alpha receptors and relaxin-1 receptors. And we have also divided our patients into groups, premenopausal women and postmenopausal women. And by a gene expression analysis, we have demonstrated that together with the decrease of the hormone levels which happens during the postmenopausal women, there is a decrease in this expression of sex hormone receptors by the fibroblast of the fascia. So we have decided to go on with an in vitro study. So we have isolated the fascial cells and we have decided to stimulate them with different amount of beta estradiol according to the postmenopausal levels and the periovulatory levels, so low and high estrogen levels. And we have analyzed by an immunohistochemistry analysis the amount of collagen type 1, collagen type 3, and fibrillin. As you can see also from the images, the expression of these three components are different in the two conditions. So when we treat the cells with low levels of beta estradiol, the cells produce much more collagen type 1, so more or less 8%, with respect to collagen type 3, 1.5%, and fibrillin, only 0.2%. This means that the fascia can become much more stiffer. There is less elasticity. The opposite situation happens when we treat the cells with high levels of beta estradiol. So as you can see, there is less collagen type 1 and much more collagen type 3 and fibrillin. This means that the fascia in this condition, so with high estrogen levels, is more soft and more elastic. So, in conclusion, we can affirm that sex hormones affect the fascia in women, modulating the extracellular matrix production by the fascial cells. And this can help to explain some sex differences in the prevalence of myofascial pain. In general, an unbalanced hormonal situation can cause much more elasticity or much more stiffness. And in clinical practice, an oral administration of estrogen may resolve these hormonal fluctuations and so help to resolve myofascial pain in women. And the sex hormones decrease that occurs with aging can have a role in the extracellular matrix modulation. And also we can understand better why some drugs like the tamoxifen that is used as, in the anti-tumor therapy in breast cancer patients can cause fibrosis, because the tamoxifen is an anti-estrogen, so it blocks the estrogen effects, and so there is, as we have seen in general, much more production of collagen type 1 associated with much more fibrosis. So the take-home message is that we aim to a personalized care. We have also published a small letter about this point because it's important to correlate any dysfunctions in hormonal levels linked to pathologies, to aging, to the period of the cycle, to the onset of myofascial pain. Only by that it will be possible to find out a more targeted gender therapy. Thank you for the attention, and also all the team of University of Padua. Thank you.